and bone grafting 1 year before presenting to me. She had complained of pain and difficulty in walking. There was no history of wound infection from previous surgery, and she had no comorbid illness. On physical examination, the scar was primarily healed. She had valgus deformity, which was correctable, grade 2 medial collateral ligament laxity, extension lag of 10 degree with flexion up to 100 degrees, and there was no neurovascular deficit. Her lab investigations were within normal limits. This was her X-ray.
All right, so who wants to tackle this one? So I'm assuming she had a lateral hockey stick incision?
Yes.
All right, so who wants to take the hardware out first?
I will take the hardware first and do the total knee in the same instance.
Through a different incision or through the same incision?
The same midline incision.
So take that hardware out with the midline incision?
Through the midline incision.
Okay. Anybody have a...
Yeah, I would make a separate incision a little bit more medial and take out the hardware that's going to be in the way. So take out the proximal screws, the kickstand screw, and then see if I need to either cut the plate or leave the plate as is when I make my tibial cut. Do it all in one stage.
Anyone think there'd be any difficulty getting those screws out on the lateral side?
Yes.
From a medial incision?
Yeah, I would make maybe percutaneous incisions to take out those screws if I need to.
Yeah, so what I would do is I will see where the previous scar is first. What's the kind of a scar? Do you have a photo of the scar?
No, I don't have the photo of the scar, but it was the typical anterolateral scar which we routinely use for the lateral tibial plateau plating.
Yeah. And how many years?
1 year.
1 year. So I would probably go by the same scar.
Yeah.
I would remove only the proximal 3 screws. I will not remove the entire plate. And, because that would be enough for me to get a primary knee inside. I'm not planning any constraint with this kind of X-ray. So I wouldn't go all the way to remove all the hardware if I can get away without it.
There is a defect in the proximal lateral tibia.
Yeah.
Yes.
I think you can use the same incision. If it's an anterolateral incision, you can go in there. If you've got enough exposure, extending it a little bit further down to remove the plate and doing a conventional implant. The only thing I would do differently is because he's got screws, it's a recent fracture. And there's a fairly significant lateral defect. I would use a stem in this patient.
Yes.
Definitely use a stem for this patient, but I'd use a primary implant.
So I'm going to be a little bit of a devil's advocate again. I would take it out through the lateral incision, take everything out. Again, take cultures. It's only a year old, it's a year incision. Let the scar heal about 3 months, come back and do a total knee under circumstances where I know there's no infection. The risk of infection with prior hardware, despite the negative workup, is real.
Okay.
As well as wound complications. Anybody have any comments on that? So show us what you did.
Yeah, this is what I did. Since she had CRP and ESR and all other parameters within normal limits, I used the same part of the same incision and extend it proximally in midline, and then approach the knee with lateral parapatellar arthrotomy and remove the hardware completely and put a PS knee with stem.
Okay.
Can't you access this plate through the midline incision slightly longer? Yes or no?
Can you access the plate through a midline incision?
Yeah.
I think without making percutaneous incisions, it'd be very, very difficult.
No, I think just at 1 centimeter on either side longer, you can definitely access that. I have done it before.
No, but there is another lateral incision. We won't get much of a distance between 2 incisions if you use the separate midline incision.
Still okay for me.
Do you have the post-operative incision, the clinical photo of the incision? How did you?
No, I don't have a clinical picture. This is the 4-year follow-up X-ray.
Well, good. So how'd you deal with the defect?
The defect I filled with cement because it was only in the anterolateral portion of the plateau.
Okay.
So this is the clinical video at 4 years.
You could have shown the scars.
Yeah. Next time I will.
Well, I mean, we're making light of it, but that is one of the biggest issues of this case. It's how you deal with the prior incision, right? So it's an incision issue, it's a hardware issue, it's a risk of infection issue, and the one thing it wasn't was a bone defect issue. But those are the important points to take home. But good job. Don't argue with a good outcome. So thank you very much.